Welcome to another edition of the Harton Healthcare Report. Today we're glad to have Dr. Gupta, who's a cardiologist here at Harton, present for February, which is Heart Month, to talk with us about peripheral artery disease.
Mark, you've won just about everything there is to win in racing. What's next?
I'd like more people to know about ER Extra.
The emergency room at Harton Regional Medical Center?
I just want them to get the best care they can get.
That just gets me right here, Mark.
Maybe you'd like to pay them a visit.
ER Extra at Harton Regional Medical Center.
ER Extra. Extra fast, extra easy, extra great.
So the subject for today is peripheral arterial disease, and this is Heart Month. So you would say, why are we talking about legs in the Heart Month? So it's all connected, right? It's all part of the same system. Peripheral arterial disease is a subject of increasing interest for everybody, and I will put the heart perspective on it, but the reason we're talking about peripheral arterial disease is there's lots of new treatment options. Heart stuff is all getting mature, and there are improvements in stents and that kind of thing, but the breakthroughs hadn't come through as much as they've come through in peripheral arterial disease. So we'll touch a little bit on that. So there are arteries everywhere in the body, right? And somehow we call it central arteries are in the chest and the belly, and anything outside of that is called as peripheral arterial disease. So by definition, blockages here could be peripheral arterial disease, in the legs could be, and same thing in the arms. So any of the appendages or the head and neck region would qualify as peripheral arterial disease. But for today's discussion, we'll talk about the legs. So, the others are probably for a later date. Just like the heart, blockages in the leg arteries develop from the same phenomena, that is plaque buildup. And I don't know about extra, but there is cholesterol and fat circulating in the blood that accumulates in the arteries everywhere, including the heart and to the legs. So interestingly, people who have blockages in the leg arteries, a vast majority of them will have blockages in the heart and neck arteries. This plaque will not kill you. The plaque in the legs doesn't kill you. It's a clue that there is plaque elsewhere, and 70% of people will have blockages, serious blockages in the heart. That's where the danger comes in. So it's important to recognize this by its own right. Obviously, if there are blockages in the legs, that's important to know. But because there's such a high risk of stroke and a heart attack in this population, it's important to recognize that associated risk. And this next line says, can affect your quality of life, making walking difficult or worse, increase your risk of heart attack, stroke, leg amputation, and even death. So leg amputation risk is really low. It is probably overstated. Unless you have diabetes, the risk of amputation from a blockage in the leg arteries is probably less than 2 to 3%. And the reason is the leg arteries are very muscular. They have a lot of muscle, and you can form bypasses around those blockages. So the risk of amputation is rather low, except in diabetics. What's the next? Okay. So, about there are about 10 million people over the age of 50 who have peripheral arterial disease. That's about 3% of the population. And if you can diagnose it early, and I'll show some pictures later on, you can certainly clean them out without surgery these days. This is almost an outpatient procedure. You come in, get your arteries cleaned, and then go to Cracker Barrel for dinner and start all over again. Love modern medicine. Well, till Obamacare kicks in, then you get one artery a year. That's all you can get cleaned out. And if you recognize it early, then our emphasis always is you look at the legs, but we really emphasize on preventing strokes and heart attacks. So what are the symptoms of peripheral artery? That's the commonest question we get asked. And people say, if you have leg pain, well, leg pain is a complicated issue. You can have leg pain from knee problems, from hip problems, from a pinched nerve in the back, to arterial problems. So circulation problems, and that's what we're talking about today, are a supply and a return. Just like your air conditioning, there's a supply duct and there's a return duct. And if one of those is messed up, your air conditioning gets messed up. So the supply side is the arteries, and the return side is the vein. So a lot of people have spider veins and varicose veins and those kind of things, and they can cause leg pains too. So if you're standing for a long period of time and there's blockage in the veins, the blood can't drain from the legs, you'll start hurting. You start aching and hurting and there's swelling. That's a venous disease. The supply side is where the blood can't get to the legs. Now the hallmark of that problem is a calf discomfort. So discomfort in the calf when you walk that causes you to stop is a sine qua non of problem in the arterial circulation. In the vast majority, about 95% people who have blockage in the leg arteries, it's a calf. And the term we use is claudication, which is Greek for I cannot, and basically means I cannot walk. You can't use it for vacuuming or dishwashing. It's a term, I claudicate dishwasher, right? I mean, I cannot walk. That's the problem. Now, there are similar problems can happen if the blood supply to the nerves is blocked in the back, and the people probably feel that they're going to the grocery store, they have to lean over a cart to walk, and that's usually the blood supply to the nerves being compromised. So that's a little different. And because it comes on insidiously, it's not like a TI or a stroke that is abrupt. It comes on slowly, and you just think, well, it's part of getting old. I just need to rest, and I can carry on. But it is not a normal part of aging. So this is what we just talked about. Claudication or claudicate is fatigue, heaviness, tiredness, cramping in the legs. By far, it's the calf, but sometimes it can be the buttocks or thighs that occurs during walking or climbing stairs. And when you stop, it gets better. That's just like chest pain and angina. When you walk, you get chest pains, and when you stop, it goes away. If it doesn't go away, that's a heart attack. Same thing, if it doesn't go away, you're going to lose your leg. I mean, that's rest ischemia. So, cramping. So we talked about this, pain in the legs. If the leg wounds don't heal, that can be a circulation problem, either supply or return. So if you have blood clots in the vein, the blood doesn't get away from the legs very well. That will prevent it from healing. Color changes, whether they turn pale or blue, that's lack of blood supply. If your leg, one side is cooler than the other, and similarly, if you start losing hair on the lower part of the legs, or there's poor nail growth. So the peripheral arterial disease is plaque buildup in the arteries, and the early plaque is very hard to detect, just like in the heart and neck, but there you can detect with ultrasound. And just the same conditions that cause strokes and heart attacks, that is diabetes, blood pressure, cholesterol issues, smoking, those are risk factors for peripheral arterial disease. So who is at risk for peripheral arterial disease? Certainly age over 50. Smoking is a huge risk factor. If you smoke and you're over the age of 60 or 65, the odds are you have poor circulation in the legs. Like I said, diabetes is a major risk factor, and the others are blood pressure, cholesterol, and associated blockages elsewhere. All right, next one. Any questions so far? I have some illustrations and pictures, but I'll be happy to field any questions at this point. Yes, sir.
You mentioned on the slide cramping and other kinds of things. Those things can happen for a lot of reasons.
Yeah.
Does it have to be chronic or just based on what?
Yeah, I don't like the term. You're absolutely right. I didn't use the term cramping. This is the slide, but cramping is very common, and by far it is not due to peripheral arterial disease. So cramps at night are cramps. I mean, what we're talking about is when you walk and you get a cramp in your leg, or people use the term cramp, and it goes away when you stop. That is a hallmark of peripheral arterial disease. But cramps otherwise could be due to low potassium, low blood pressure, certain drugs, diuretics, and so forth. Yes, ma'am.
A lot of those symptoms are the same as neuropathy. Does that happen?
So neuropathy is often associated in people who have peripheral arterial disease, but just like the terms, it's a problem with the nerves, not the arteries. So neuropathy is typically not worsened with walking. Your feet are numb, they're heavy, they're cold, but that's at rest, and more often it's worse at nighttime. Neuropathy is worse at nighttime. Peripheral arterial disease is worse with activity. The hallmark of arterial problems is exertion will make it worse. So how do we diagnose it? A good physician should be able to diagnose it by history alone. And if we all did our job better, the cost of healthcare would go down. But history taking doesn't pay very well, so we have to order a lot of these tests to get paid. So we can check your blood pressure in the legs, and that's a clue. So that's called the ankle brachial index. There's a push by Medicare for us to check blood pressure in the legs and then compare it with the arms. Normally, the blood pressure in the legs is higher than the arms, and if it is lower, that's a clue there's a problem somewhere. It doesn't tell you where the problem is, but there's a problem somewhere. So you can ask your primary care doctor to do that. That's actually a mandated part of the physical examination. Yes, sir.
If you have a big pain at night when you sleep and you get up and you're just about to fall, it makes you fall and almost dead. What causes that?
Not peripheral arterial disease. You check your partner, she may have just kicked you at night and you didn't realize it. So if the ankle brachial index is abnormal, then the next step would be an ultrasound. And there are others, CAT scans and MRIs, and those get expensive. So for screening tests, just blood pressure is a good way to start. And just like heart problems, we tell you to eat healthy, walk, take your medications, and so forth. So in some cases, procedures and surgeries are necessary. Again, we don't make money off you guys if you eat right and walk, so we rather you come in for surgeries and procedures, and we'll go over that. But prevention is really the key. No, that's fine. Go ahead. So to reduce your risk, quit cigarettes, get your diabetes, blood pressure, and cholesterol under control, and less meats and white starch, of course, and walk 30 minutes a day. Those are the Heart Association guidelines. This is where you can get more information. Where's our numbers? No? Okay. That's it. We just lost the audience. Okay. Okay. Mm-hmm. So we actually are very interested in peripheral vascular disease, even though nobody thinks of a cardiologist when they think of leg pain, right? Nobody would think of coming to a cardiologist if your leg's hurting. And we are struggling to figure out a way to change that. Because leg problems or leg circulation problems are so intimately linked to heart problems, we actually have a team here. that involves us very early if circulation problems. So we have a vascular surgeon, we work with the radiologist, and we work with many of our podiatrists who are very quick to send us patients when they find problems in their legs that result in, and when patients come to see us, they're perplexed. They say, well, there's nothing wrong with my heart. I don't know what I'm doing I got a wound in my foot that doesn't heal, and they send me to you. So I would like to make that connection. Okay. So this young lady is a lady I've been seeing for years. She's one of my wife's dear friends. She has diabetes, and she loves to eat desserts, and I think my wife enables all that behavior because she'll eat with her, unfortunately. And she had a wound on her left foot, which this is the thigh bone that is connected to the shin bone, and I'm sorry, but anyway. So what we are seeing here is this is the bone, and this is the artery. This is the hip area, and you see it's a straight, long artery. And then there's the knee here, and of course we can. So you see how it narrows down here. There's some plaque buildup up and down, but this is the area where it almost gets down to a thread. So when that happens, the foot is not going to get blood. So it's like if you had a row of houses and the water main at the first house, all right, the water main gets narrowed, well, the house farthest is going to suffer the first. So the foot is therefore the first area, or the calf is the area where this starts to, even though the blockage is in the thigh, the symptoms are developing in the foot or in the calf. Does that make sense? All right. So this is years and decades of good eating and good living. Okay. So what we do is the same person, and you see this is an outpatient procedure. It used to be you had to be in the hospital for 4, 5, 7 days. But we're able to go in with a little catheter which has a blade on the inside, and it's a little rotor-rooter that scoops up the plaque, collects it, packs it in, and you can get it all out. And it takes 2-3 hours, but it's really comfortable for the patient. There's no incision. Kills our backs doing it, but it's really good for the patient. Okay. So this is the hip bone. You see how this gentleman had pain in his whole leg, and he could hardly walk across the hall. And you see how severely narrowed this area is. Now, this is right across the joint. So in the previous example I showed you, you can sometimes put stents in the leg arteries, and a lot of people do that. Stents are easy to put in, but they are not a good option. The legs are very muscular. The stents cannot withstand the stress of those muscles twisting, turning, bending, and they don't last as long. Where stents in the heart are a perfect solution to these blockages, they are not a good option. Or at least so far the stents that we have are not a good option unless it's a bailout situation where you're trying to prevent an amputation. And so there's an added complication because you're right across a joint, so you can see how if you do this, the stent will be bending and it'll eventually fatigue like any other metal. It'll crack and then there'll be problems. And stents cannot be taken out once they're put in. So we like not to put stents in unless you've tried every other option. So this block here, this is actually calcium and plaque. And there's another severe plaque here. So that's a huge artery that's about 95% blocked here. So this is the device we use between the two dots. You can see how tiny it is. This artery is about 7-8 millimeters wide, so it's about 1/3 of an inch. The device itself is about 1/10 of an inch in diameter, and it just cleans the whole artery out. So this is a situation where you will not even have pain in the legs. This problem is in the belly, These are two arteries that go into the leg. And this young woman came to us from Fayetteville. Every time she would walk, she would have back pain and heaviness in her buttocks. So she was having all kinds of spinal shots and injections to her back. But this is the main aorta, you see, and how narrowed it gets here. So this is the groin area. So the blockage is this is around the level of the belly button. So this would cause pain in both extremities. Now, this is a situation where you have to put stents in because you cannot clean the artery that high up. It's the main artery, and if you tear it, it's instantly fatal. So this is a stent that goes up here. It's not difficult to do. It just takes 30 minutes. In the past, you would have to open the person's belly, put one end of a bypass here, and put one down and bypass. That's the old way of doing surgery. We walk out of the hospital the same day after this. It's a similar situation. This is the other side. It's a mirror image of what I just showed you. Another person with diabetes had a lot of leg problems and a non-healing wound. And if you notice, we don't put stents. We just clean that out. So now, this is another area I think I want to show you. So this young lady has diabetes. She works, and every time she walked, she would have problem. And the calf would tighten up. Can you show me the previous picture? This is her left leg, and this was her right leg. So you see the blockage here, and let's see the left leg. So the left leg, this is completely blocked from here to here. There's a ghost vessel. Which leg would be worse? Same person. She only has two legs, so it's not a trick question. Left one? That's what I would think. But so the problem here is, when we say come in early, the problem here is this is totally blocked from here to here. Now, I'm going to show you where we can clean it, but it takes a long time. So what I decided to do is fix the right leg first, and it took care of her symptoms completely. And the reason is, on this side, she's already formed bypasses. All these little things you see, you don't see on the right side. They're extensive bypasses because this is the thigh artery. It has all this muscle, and it's filling this through the bypasses. These little threads that you see are nature's way of taking care of business. And because of these bypasses, can I go to the previous one? She didn't have much symptoms on the left side, but you don't see any of those little things on the right side. So in this situation, it's better to leave it alone. Because if you go in and start operating, you're going to disrupt those little channels that she has formed on her own. So you see that elsewhere. You see that in your heart. You see that even in the brain sometimes you see bypasses. So this is an example how the body can take care of complete blockages. So this again is the hip area. This young lady came in with a blood clot here, and her foot was cold. She had no pain in her thigh or knee, but had a blue foot. And this whole area, you see there's a discontinuation here. So we went up from the right side, came down, and we were able to same way clean it out. Okay. Next. So this is what it looks like. So that same device, it sucks out plaque and clot and so forth. So there's no stents, nothing is left behind. So our motto is leave nothing behind, because the lawyers will always find you if you leave something there. Okay.
Did that lady or person, did they have diabetes also?
Smoker, no diabetes, just a smoker. Okay. So this gentleman is one of my favorite patients. He is only 40 years old, but was a smoker, had a massive heart attack, and lost his right leg. It was written in the paper, and he had amputation. And this is his left leg. And he started developing wounds on his left leg that wouldn't heal. So this is the knee now. And you see there's one artery going, and this one is severely blocked right here. So now this is an area where we can clean, but because it's a tiny artery, can we see that? We decided to, and this is not over a joint, it's not a long area. We just put one of the very short stents. This is only about 20 millimeters, about an inch. And this is a good situation to put a stent in because you can use the hot stents and so forth, which are very effective. So that little blockage took care of the wound he had developed. So we have a wound care center here, and that's why we have a lot of these folks coming in with this artery is behind the knee. There is just down to a thread, and the wound wasn't healing. In fact, he had a bypass in 2010, and the wound from his bypass hadn't healed. So finally, somebody decided to look into it, and that's what they found. And this is after we cleaned it out. Again, it's behind the knee. You can't put any stents or anything like that. So you have to clean it out with one of the atherectomy devices. So this is from today. This is what I was doing before I got here. This gentleman is 40-some years old. He works on an oil rig off the coast of Louisiana. His mother used to work for us, and he actually saw my wife on Friday. Was having pain in his leg, and they did an ultrasound, and they found there was no blood flow in that left leg. So we admitted him, put him on blood thinners, and all this is blood clot filling from top to bottom, all this hazy business. So we cleaned it out. It's a good thing I did it before lunch because I don't think I could have done it afterwards. And I'll show you what we got. So hopefully there's a pic. This is a syringe to just get, and this is all the stuff we got from his thigh arteries. Did I ruin your appetite? Yeah. Good. They don't serve anything healthy on the oil rigs, he told me. It's all fast food. Yeah. So the yellow stuff is plaque, but when the artery shuts down, it starts to form a blood clot. So you see this. This is probably much longer than it would be in the artery because it's really packed. It's compact. It's like a sausage, if you will. So this is the blood clot intermixed with the yellow plaque.
There's one place women of all ages can find the care they need, the Women's Center at Harton Regional Medical Center. We're a full-service women's center with comprehensive obstetrical and gynecological surgery. Our excellent customer satisfaction rate is a reflection of our commitment to excellence. To serve you even better, we've now remodeled our facility. Our family-friendly birth center features private labor, delivery, and recovery suites. For every stage of your life, we're there for you. The Women's Center at Harton Regional Medical Center.
Thank you for joining us for another edition of the Harton Healthcare Report. We'll see you next time.